Hey, hello.
It's the best use of transport.
I know.
Also,
This is all the textbooks that I left in this medical library.
also, pediatric books, yeah, when you use it.
Yeah, just.
Oh, you can open that.
Sure.
Yeah, we can let the here.
Did you get into again? I know.
We need to go to work out how to get it.
There'll be some classics in there. It's the name of it. Well, I said.
What's that working?
I think that everything.
Is it Sheila?
Yeah, well.
Sure. Can you see the ADHD prescribing sheet that's on the
Yes. On the PowerPoint here, it's
on
clear.
the PowerPoint? Okay, you can see it.
We're just trying to get it up and running.
Back on this one.
Let me go down.
So it's not having your breakfast food is a close one.
It's there.
Is it-
Just won't let me.
So that's where I asked Esme. Yeah. The response was. Is it for expensive? So I think kind of introduce. Yeah. And she
Let me go.
said.
Let me go.
No, it's long to it. Week. I think later. She's there. Dermatology. One day a week and then extend that a little bit and. Amy, it's not like that. So you told this.
So we're still waiting. Technically, there should be another 4 people coming in online. I would hope. They were all sent reminder messages yesterday. Does everybody get my text messages? Remind me. Yes, that comes today, so you don't forget. Yes.
In Queensland.
Because you went on the list.
Yeah, if you can get it.
Nice. Know what's going on. Sorry, I can always make sure I'm this.
Sarah, can you provide attendance thing that anything you want?
But how many?
You said she doesn't.
You should get all the attendance certificates that I sent out to you. Okay, and so after each one, I send you an events their attendance thing to say that you're attended, which you can actually then forward to your governing body, if you're whatever you're registered with. We don't have a CPD obviously on this one, but it is proof of continuing education and learning, so you can
For me, because it's. Now the people staying with us.
yes. So if you haven't been sent, then let me know because I can resend it.
I'm gonna have a look because my memory is bad. There is an hour. So I may have just typed it into certificates and not even paid attention. I'm gonna. It's almost the one with the sexologist.
Oh, it's very interesting actually. It was really good. Shouldn't talk that sex. No, it wasn't.
So it's a secret. It's a
Yes.
That's it. Was it another well-being, look after yourself type thing?
Yes, but it was quite good. Some of the information he shared. Yeah, I quite enjoyed it. It was. It's like I think all our morning one presentations, I've been actually pretty overwhelmed with them. I think they've been magnificent, all the information, and that's why I get drunk when people don't register for them, don't come along.
But if they don't know it, for them it's just another thing. I think once you've been, do people tend to return or do you have people that come once?
A bit of both.
Yeah.
A bit of both. I think getting it more people understanding that when you come along to these, it doesn't have to be your primary,
No.
you know, what you're interested. Well, if it needs to be what you're interested in, or it might tack on to what you would use in your practice, or everything is integrated anyway. So I think just that extra learning and information that I found I learned a lot from anyway, just see what else. So, but I think we'll start. If people pop in, they'll pop in soon. Oh, there you go. Here's Emily. She's popped in. Hi, Emily. Still waiting on our people, but that's okay. Hopefully they'll come soon. Thank you for joining us if you're online, and I'll have over and just thank Andrew for offering to do this, and we really appreciate it. So this is being recorded and will be available on our website and in my next newsletter as well. So if anybody misses it or you want to share this information with people in the organisation, it will be available as well.
Thank you. Thank you everyone for coming. For those who don't know me, I'm Andrew Sobering. I'm one of the paediatricians Broome. This is my second last day for 3 months in Broome because I'm about to go to Kalgoorlie to sort out their mess. So I'm going out in the midst of the wet season, which is both very sad and very happy because I feel like better off living in an oven. So I'm going to talk about ADHD, more about prescribing ADHD, but it is I hope it won't be right. It is very topical in the last 12 to 24 months and will remain topical, I suspect, for the next few years as there is a big demand for diagnosis and management of ADHD or the wait lists, and that is driving government policy in the full child development space, but particularly the ADHD space, has for the last 2 years, probably will for at least the term of this current government. I'm going to start by acknowledging the ARA people, the traditional owners of the land, my respects to elders past, present and emerging. I also pay my respects to the elders of the other lands and people are sitting today, the one up here in Broome. This is not a talk about diagnosis. Do not worry, that slide is for information. But ADHD is a condition that is listed in DSM-5, and it is a combination of inattention, hyperactivity, and impulsivity. There are a list of criteria that must have been present as a child. That's the important bit. 17 and under. Used to be 12 and under, hasn't progressed. That is actually one of the few things we're doing to female-ify, if that is a word, the criteria, because girls often present later. Traditional ADHD, DSM-4 and DSM-3, quite 12, and largely suited boys. But you've got, and it's not just that you do these things, because I think on any given day, any one of us is probably made all the criteria for that. It's that you do them often and that they are functionally impacting. And I think they're the two most important words, the two most important concepts that have got to functionally impact you. So the fact that you can scatterbrain, if you're doing really well, you probably don't have the last beat of ADHD, the disorder. And if it's not occurring often, that's just called life. So they're the ones for inattention. They're the ones for hyperactivity, and you don't need them all. You need a majority. So you need 6 or more, 6 or more, 6 or more of those symptoms. Remember, it's not a diagnosis. This is a syndrome. It's a collection of symptoms. It's a syndrome. It is caused by probably a number of different pathologies going on in the brain which we don't understand yet. That gives you a number of different outcomes depending on if you've predominantly got criteria, like lots of criteria in the attention and not many in the hyperactive, so you are predominantly inattentive. But you can be purely inattentive, it's actually quite unusual. You can be predominantly hyperactive and impulsive. That is actually the rarest of the three. To have predominantly hyperactive impulsive symptoms and not to have as many of the inattention, or the majority who have both. And the one I think I forget to do routinely, we are supposed to specify if it's mild or if it's depending on the severity of functional impact. I don't particularly like that, so I tend to ignore it. This is a very interesting topic of ADHD epidemiology and the prevalence of ADHD. Studies have shown, studies in the early part of the last decade, showed that global prevalence hadn't actually increased very much over 30 years, suggesting that it's recognisable, not diagnosed, not it's increasing. Having said that, I amended my slide yesterday for this solarium paper from 2023, which has a global prevalence of 7.6% in children, because the previous one was 5.9. But that was children and adolescents, and if you look at adolescents, it's 5.6. So perhaps that number is the same, it's just a different population you're looking at. But what you can see is the numbers are dropping as you get older. So adults considered 2.5, I suspect that figure now will be high. But once again, I don't think it's increasing, I just think it's being increasingly realised. And there is a persistence of functional impact and symptoms into adulthood of at least 60%, though I did see a very small number of papers suggesting it was in the 70%. So effectively, the majority of people with ADHD as a child will have ADHD symptoms as an adult. Doesn't mean they have ADHD in that they may not need medication, but they have persisting symptoms and persisting functional impacts. So this is going to be a growing health problem because these children are being diagnosed, know they'll persist, and they'll probably want to seek treatment increasingly as an adult, given they have had success as a child. Gender has changed recently. Child adolescents were thought to be 4-to-1 on stage, and certainly in clinic settings. I think the majority of paediatricians would agree. 4-to-1 is probably what we see boys to girls. Teachers not agree. Yeah. Not true. Because in adults, there is a minimal gender difference. And we increasingly, I've just said 70% persistence into adult life. That means we presume, and there's one of two thoughts, that girls are different, that they have different, women have a different condition that mimics ADHD, and that has been postulated, or the preference for most of us is not diagnosed it in girls, which is where I think we're probably sitting. So, and not in such a probably agrees with them. We're not diagnosing in girls. The reason why we've got to diagnose it in girls is unclear. They are certainly, women are diagnosed. They're diagnosed at quite a high rate. They are girls and women are much less likely to be offered medication as prescription. Why? Probably takes us into the realms of social stigma, as I've said, gendered expectations of girls versus boys. Necessarily wants to turn this into a battle of the sexes thing, but yes, I think there's a lot of sexism in the way we manage girls in schools, in life around this condition. Other diagnostic criteria, particularly hyperactive, there aren't as many hyperactive girls. Someone used to say ADHD is a 7-year-old boy on steroids. Most girls are not 7-year-old boys, and never will be.
Does this go back to women cannot be exhausted and men can't?
Possibly. One of the others is that girls present differently. One of the thoughts, and it's one that I probably a part of, along with the gendered expectation stuff, that hormones play a role, and particularly estrogen changes. Girls, in my experience, often describe deterioration in puberty. That they could cope, and now they can't. They become anxious, and guess what? They get diagnosed with incorrectly, and then they're chasing that for many years. And women at the other end of their reproductive life, so menopausal, perimenopausal women,
Pick me.
we know they actually often find their dose. So maybe it's an ADHD, maybe ADHD and estrogen. I don't know. The figure, is testosterone driving more hyperactivity in boys? These are all postulates that I'll have to test. So, are there other reasons why women do, or girls do not get diagnosed as often as women? My strong feeling is gendered expectations are possibly hormones. Interestingly, it's more likely to be diagnosed in children born in the second half of the school year. Now, that has been used to beat us about the head as paediatricians, that we are using age You know, young kids, obviously they can't as much as old kids, so we're drumming them up. Equally, are we underdiagnosing the older cohort? I suspect the older kids we're not, because they're able to manage, we're not. We're noticing them and saying, oh, well, in the middle, they're actually doing a bit better, so we're not diagnosing them. I suspect it's an underdiagnosis in the older cohort rather than an overdiagnosis in the younger cohort.
I understand those to adjust because they are a little bit older, so they.
Well, it may just be expectations are a little bit different. Yeah, you set your expectations to here and then just managing them. It's hard to know, but I don't think we are we're more likely to diagnose it in younger kids, but I don't think it's because they're younger. I think it's because they're probably not as mature. This is been, well, it's one of the revelations for me, is the heritability of ADHD. ADHD is a genetic condition. 5 to 10 times more likely in the parents and siblings of children who are diagnosed with ADHD. It has been said that there is a 50% chance if you have ADHD that one of your children will. So if you've got 2 parents with ADHD, that means there's a fairly strong chance for your child. And it's also more common amongst biological relatives. You'll have families that are seriously families where there's ADHD everywhere in that family. Diagnosed or undiagnosed, it's everywhere in that family. The parents that chronically come late to appointments or miss them because that's their problem. They've got it too, they're just not diagnosed. Fathers or mothers that have been through multiple relationships. I mean, the best I had was one woman who had 5 children by 6 fathers. I'll let you think about that one for a second. And yes, she had 2 men on the same day and couldn't work out who the dad was with one of them. And she literally couldn't, he didn't look like it, and the kid didn't look like either of them. So she couldn't actually work out who the dad was. And whether it's defined, however you define it, it's 70 to 90% heritable. And where does that place it? Not far under heart. It is the second most heritable DSM condition after autism. Autism is up there with height, but that's how genetic this is. This is not an environmental condition. This is a genetic condition that may be manifested more with certain environments than others. And not for today, but I can talk about what my feelings, why this is so, why we genetically, why it's remained within our evolutionary processes. I can do that offline. Having said that, environmental factors do play a difference, and particularly relevant to our cohort, psychosocial adversity, which is different to low socioeconomic status, if you look. It's much more correlated to have psychosocial adversity, which is very big in our cohort. Alcohol exposure, anti-alcohol exposure, should be anti-over cigarette exposure, and being full birth, which probably relates to cigarette exposure, alcohol exposure, and psychosocial adversity. So that's probably a compounded variable from the number of other variables. And that, if the odds ratio is 1, the odds ratio of 1, so that is much more likely. So you're nearly 4 times as likely to have social adversity in utero to end up with ADHD. Probably part of the reason for the postcode effect. There are certain postcodes that have more ADHD than other postcodes, and it probably relates to low social things. That's cigarettes, exposure, and low social adversity. Now getting on to what is effectively why we're here today, I'll just talk about treatment. And I'm still not going to talk about frontology. I'm going to talk about non-frontology first. And the first is, very importantly, these children go to school. So it's nice they don't always can provide literacy and numeracy support. It's nice to have a teacher that knows what they're doing, sits the kid towards the front, minimises length of instructions, gives the kid breaks, things like that. That is some support. And it may help particularly those with more. to manage. Probably isn't going to stop the kid who dances off everywhere because there's bounce off everywhere. The actual busyness of the classroom is enough to make them bounce off everywhere. So this is just partly to provide that supportive environment for the kid, and from minor symptoms may actually be enough. And well, something we don't have a lot of in the Kimberley, psychology, but also social workers play a big role. I mean, most importantly, they can do learning assessments to work out if they've got a problem. Behavioural management, psychological management is the first line for mind kids. If you can do it, you often can give them the skills to manage themselves. Help with organisation and planning. You can teach parents how to parent these kids in a more appropriate way. These kids often do not respond to what called parenting. It's not, the kid's not being defined, or they're not being defined. The kid can't help themselves, they're impulsive, and they're going to do it again if you put them in that setting because they're impulsive and they're not thinking, and they're not looking, go, I don't know why I did it, because you know what, they didn't. Social skills training. You could do CBT, comorbidities, and MSD, multi-systems therapy, and that is for very severely affected conduct disorder child, which is quite rare. Speech therapy can be useful. OT is quite useful. The alert program teaching self-regulation is actually really helpful, particularly for the more severely affected kids in concert with medication. It can help give the kids some tools to manage their own, regulate their own emotions, to see the signs. They've got to bring their impulsive down to the point where they can actually react to these. But if they can, a lot of these kids, they don't want to be naughty. They don't want to be in trouble. They don't like it any more than anybody else does. And they get really helplessness because they can't help themselves. So I'm no good. So if you can learn, give them some control, that actually puts them their self-esteem. But also a lot of these kids have fine motor issues. And these kids need tremendous help with their organisational skills. Now, it's a few things that don't work. Diet. Yeah.
What is the other program? Do you have to pay for it?
Not in Jane Pierce does it in Brew. So it is a registered program. And yes, OT, well, it's run by OTs. So yes, if you go privately, you have to pay for it. If you're not going privately, you probably wouldn't. But it's run by OT. It's around engine. It's the engine run. Yeah, when your engine runs fast or slow and things like that. Yeah, amongst other things.
It requires parental involvement.
It does require.
Everyone has to try it every.
Yes.
And it's like 6 sessions. Good. Yeah, it's really good. So the parents don't off stimulate the child.
Yes. Neurofeedback is offered in Perth by.
Sorry, you went for diet.
No studies have ever shown diet changes.
All the
They might affect behaviour. And one colouring, I cannot remember which additive was shown to affect behaviour. That just shows how bad psychological studies are detecting the sudden changes from behaviour, because every parent will tell you they can't have that. I've got a simple answer. You have usually died because you haven't had Coke or red food colouring. So if you can find colouring, just don't give it to that kid anymore. Because it's usually not an essential nutrient. But the fine old diet, fed up diet, the additive-free diets don't work in population studies. It is also very hard to randomise and blind for those. Because if you're not giving Coke, it's obvious you're not giving Coke. It doesn't seem to affect in studies ADHD symptoms. I'm not saying individually, but it's not a treatment that I would recommend. Parents have come up with themselves. Neurofeedback, EEG neurofeedback has some promise, certainly done in Germany in research programs. I just would say that what one thing that you're offering is not done to any studies ever. It is their own thing. Computerised memory training, like Cogmed, which is no longer a functioning thing, robust, or Lumosity have been suggested. They are really good in a test. They're not generalising. So that's the problem. And the problem is these are impulsive kids. They have low frustration tolerance. And they don't like getting these things wrong. So it may actually be counterproductive. And now we're getting on to the ultimate reason why a little bit of what I was going to talk about, which is psychopharmacology, and particularly psychostimulants. And I'm going to come back. I want you to keep this in the mind as we go on and talk about psychostimulants. And that is, when we talk about the prefrontal cortex, there are almost like two things that are going on. There is the signal strength that is coming through of what you want. So, the good things, the learning, what you're trying to do. That is, if you've got a low signal strength, it tends to mean that you tend to fidget or get out of your seat and you lose focus. There is also extraneous stimulation, which, for the want of a better term, noise. And high levels of noise, so high levels of extraneous stimulation, will be associated with rapidly shifting attention, obviously, distractibility, and an inclination to forget. So what you are trying to do is reduce the noise and increase the signal. Like a radio. If you've got lots of background noise, you can have an impedance monitor and you can have a signal strength improver. And that will give you a more clear signal. And that's effectively what we're trying to do with psychostimulants. Noradrenaline increases the signal strength. Dopamine reduces the noise. So low dopamine, high noise, low noradrenaline, low signal strength. And this is a very busy slide, which we'll come back to later, but this shows the effect of amphetamines, so DEX in a setting, atomoxetine, 1% and Klonopin, and Ritalin. Ritalin methylphenidate is a pure dopaminergic active. It doesn't have activity against noradrenaline. Dexamphetamine has activity against both. It's predominantly dopaminergic, both by acting on the receptors on the presynaptic neurons, but also getting into the presynaptic neurons and pushing more dopamine out. But it also works on the noradrenergic pathway. Atomoxetine is a selective noradrenaline uptake inhibitor, so guess what that works. And 1% is down here. And basically, they work in opposite ways. To decrease the noise, you open calcium channels and increase cyclic AMP, and to increase the signal, you have to close the channels. We'll come back to that slide. Stimulants. We weren't going to go live from stimulants. They're the mainstay of pharmacological treatment. And these are the stimulants. There's short-acting methylphenidate, or used brand name Ritalin, Artige, Brubifen, Ritalin LA, Concerta. They're the long-acting versions. So short-acting methylphenidate comes in 10 milligram tablets. It is very short-acting. It's not a daily dose. Long-acting, we have two versions. Modified release methylphenidate, Ritalin LA, so called Brubifen, it's generic. There is now a new generic as well. That lasts 6 to 8 hours. It comes in a gel pack with little beads inside. And Concerta, which is Oris technology, so it comes in plastic, pot with a laser drilled hole in the end and a coating of short acting, and it's an osmotic driving pump. So water comes into the plastic and pushes out, steadies through Concerta. There's been supply issues of long-acting Ritalins all year. The Ritalin LA was probably coming to an end. I have heard over the weekend that Concerta might be coming to an end as well. But PPA has Concerta keep going until the shortage kept going until October 2026. So you can get it from Switzerland and legally import them, but possibly even to legally import from Switzerland. Amphetamine, you've got the amphetamine-based ones. You've got Dex. Dex comes in 5 milligram tablets and only 5 milligram tablets. And Dex is the oldest drug to be shown to work in scar treatment. 1938. And it was first used to treat hyperactivity. It was there used to keep bomber crews alive as a bomb of duty, but it was awake while the bomb duty. But it was used in this. Ritalin, much younger, the late 1950s, early 1960s. So and lisdexamfetamine, which I'll talk a bit more in a minute, which is prodrug, which is actually the first new stimulant, but it's not really. Because lisdexamfetamine is a prodrug. It's a prodrug combination of the leaves of lysine and dex. Unlike most stimulants, which are passively absorbed across the gut membrane, it's actively absorbed. It's got lysine in it. It's metabolized somewhere in the body by a lysine hydroxylase. We think it's in the red blood cell, but no, it's found in the enzyme. So we don't know what does it, but it's got to be a lysine hydroxylase. That's the only way it would work into lysine and dexamphetamine. And because that is happening inside the body, there is almost no first pass effect through the liver. So effectively, what you take is what you get, which is why you cannot and should not try and take short-acting dex and make a long-acting dex dose out of it, because the first pass effect will interfere with that. It's got a couple of indications, ADHD obviously, but it also is indicated for binge eating disorder in adults. These are adults who sit down with a pack of potato chips watching the TV, and the pack of potato chips just binge eating. Binge eating disorder can be treated with dexamphetamine. It probably has dopamine base. It's probably listening to some of the psychiatrists, I think it's probably part of what ADHD, but it's an adult condition. I don't know about it. Do I see binge eating in children? Yes, but so what do stimulants do? They reduce your impulsivity, they increase your concentration, they have better social skills, they reduce your activity levels, they actually reduce the likelihood of long-term substance use disorder. The best study that was ever shown of that showed of 16-year-olds treated and untreated, all of them had ADHD, the rate of substance use disorder in the group that were treated was 50% better than the group that was untreated. The worst study for those results, the worst result, was no difference. So it is not a gateway drug like people have used against it in the past. There is an 85% response usually to a single agent, or it can go up into the mid-90s if that agent doesn't work properly. You can go to, and it's 95% response if it's combined with psychological and behavioural management. And over time, that the behavioural management becomes much more important. So this is not a drug by itself. It's not a treatment by itself. It's part of the treatment package, including behavioural management. And what we're trying to get out of this is better school achievement, better social achievement for the child, or friendships, or sustained friendships, better engagement socially, better marks academically, because one of the big outcomes with ADHD, one of the big determinants of long-term outcome, is how the child does at school. People who do well at school don't tend to do well in their economic life. I think that is actually a study. Yeah, that's the biggest outcome. Having said that, people with ADHD treated and untreated are much more likely to die in characteristics. So this has real world effects. ADHD has real world effects on people's social lives, economic productivity, and in fact life. But more importantly, if you're doing better, you tend to have better self-esteem. You're not in trouble as much. Your behaviour tends to be a bit more socially acceptable. Better is probably not a good word there. Socially acceptable is probably a better word. Although some of that achievement does depend on if you've got other comorbidities, which I haven't really talked about, but anxiety, depression, conduct disorder, opposition, other things that will obviously impact all of those outcomes. Side effects, are well known, well studied, and yes, they look extensive. For the majority of them are not huge. For most kids, hugely problematic. Appetite suppression can be problematic. Yes, can be quite significant for some kids. It often is. It often doesn't present in that. It often is mild, or that sometimes it's subjective. If you look at their weight, they won't think they study lunch, so they eat in the morning and they eat in the afternoon, but the caloric intake is okay. Some cases it can affect their weight in slowing it, or it actually causing it to drop. In populations, however, growth is not stunted. We've got a number of studies now. There's one that was done where they actually looked at men who were treated and men who weren't treated, and their growth curves, the bell curves, directly aligned. Whereas you expect if there's any sort of something, the treatment would be shorter on average, and they're not. And then there's been two studies now, one done in America and one done in Australia, that followed a cohort and it showed growth flattening at 15, but they caught it up by 18. So it doesn't stunt growth. Having said that, I'm sure most of us wouldn't like the fact that a kid's just not putting on weight. If losing weight, we probably would be uncomfortable with that individual child. But yeah, population-wise, I'm pretty safe to say it does stunt growth. And sleep disturbance is the other big one for kids. So
That could be stunting growth.
that could also be stunting growth, yes. Worsening anxiety, if anxiety is a significant comorbidity. If primary, if lowered self-esteem is the reason a child is anxious, then treating their cause of their lowered self-esteem probably make them feel better. So it may in fact help treat their anxiety, but yes, it can make them anxious. Yes. Abdominal pain is quite common. Headaches are quite common, both of which, particularly when you first start medication. Most kids get used to it, some don't. Certainly have kids who get migraines, some of them get signals. Tachycardia is common. I don't know what my colleagues' feelings are, but I'm not sure of its significance in children, because children's heart rates are fast anyway. I am hearing from my adult colleagues it is somewhat of a concern in the adult world, that some of the cardiologists are concerned about almost stimulant-induced cardiomyopathy. So, but the effect to which it is a problem in children, I don't know, because children's heart rates are really fast anyway, and they're very dynamic circulations. Hypertension, on the other hand, can be a significant issue for kids and adults. Having said that, a lot of the kids I've seen with hypertension and treated with stimulants have hypertension, and you don't treat them with stimulants, they've got hypertension. Because we're now dealing with a different cohort of kids than we had before. We've got many more kids with lifestyle type issues, obesity, diabetes, metabolic syndrome. So yeah, hypertension is an issue, and we should be measuring blood pressure in kids, all kids, most of the time. Yeah, it should be part of our basic exam. I still think it's not, but it should be. Tics are interesting in that a percentage of kids with ADHD will have tics, whether or not you treat them with stimulants. The percentage isn't vastly different. Treated with stimulants or not treated with stimulants. I think the kids who get tics on stimulants, we're going to get tics. Stimulants may make tics worse in an individual child. And that may raise the tic from being not much of a problem to being a problem for that child. Yes, but I do not think tics are caused by stimulants, and that was a long time before were tics caused by stimulants. I don't think they are. The other thing about tics is they tend to come on in that sort of late childhood period. Guess when we know it? 6 to 12. Guess when we know it when I was ADHD. So the fact he didn't have tics when we started the treatment and now does, well, yeah, they were probably going to get it anyway. And a lot of parents, when I raise this with them, go, what is that in? We just haven't really noticed. Or, well, like his dad. Yeah, tics is genetic. Well, it's a little bit like his dad. Mood disturbances, worsening anxiety, depression, anger, which I think is the most common, by the way. These kids get suddenly incredible, horrible angry. And yeah, some of them are angry anyway, but they just turn to horrible. Angry little kids, and some of them turn to angry ants who are just absolute plastic kids. It's rare, it's unusual, but it happens. Increasing obsessionality is the other one that sometimes happens. Possibly more commonly autistic or peri-autistic group, where they just suddenly become very obsessional, very things to be done certain ways. The one that a lot of parents will often become absolutely terrified is the zombie, profoundly flattened child. Not saying it doesn't happen, it does. I can't actually remember the last time I had it. Not very common. Certainly isn't common. I think it was common in Western Australia when people went with bigger doses to start with. I think now we've probably switched to the more psychiatric way, a little slow. I don't know what your feeling is there. I just don't see it as much as we used to.
I had one child.
Yeah. The last one I remember actually was a young child. I think it's more in the young children. And this child, when we took them off medication, and it's a child statistic, and impulsivity was a child social skill.
Sorry to constantly interrupt, but is this something that is more experienced by the kids themselves and the parents just think they're calm and quiet, but the kids
No.
actually say,
No, this is one of their parents, not just the child.
okay.
These children are flat. I mean, they really are. They're completely. Zombie is a good description of them because they're vacant. Kids, well, particularly teenagers, will complain of feeling flattened. But I have a bit of a line which I sometimes say is, my witty repartee is your obnoxious insult. So they think they're not funny anymore. No one's laughing at them. Well, there's a reason for that. It probably is they're not being stupid now. My friends say I'm not as funny, they don't like it. No, because they're getting into trouble now, not you. So it can be subjective, but this is real. These kids are vacant. It's horrible. It's a very horrible side effect. Diversion is perennially a concern of the Schedule 8, stimulants being one of them. It is much more of a concern with short acting. Okay, deaths in the playground, changing the rules 20-something years ago, and prescribing in Western Australia was to raise the street price of deaths from $1 a tablet to $5 a tablet, because you just wouldn't get as much. Ritalin, less of an issue, but it is divertible. Long-acting, much less of an issue, and in fact, there's some very early studies suggesting lisdexamfetamine might actually be useful in methamphetamine use disorder, but like methamphetamine wasn't as effective, and over 12 weeks it not to work as well. But it potentially you could use it as diversion therapy. Because it can't be broken down, sorted, or anything, don't do anything. So it's a bit pointless. Coming back to that, we're going to now talk about the non-stimulants, and we're going to talk about the alpha blockers and the serotonin, specific neurotransmitter reuptake inhibitors, which work on the signal side, the increasing signal strength side. First one of those is guanfacine. Guanfacine, for those who like these things, is a selective alpha-2A receptor agonist. But we don't really know how it works. We know it's post-synaptic, and it probably stops the reuptake of. So it's a post-synaptic thing, and it's in the adrenoceptors, it's in the midbrain and prefrontal cortex. Prefrontal cortex is important in ADHA, and particularly the regions involved in things that are problematic in ADHA. It was guanfacine is an antihypertensive, and was first approved in the US in 1986, but wasn't approved anywhere else. What happened and from the 1990s, certainly I used to have kids coming to see me from America who were diplomats kids, and they get guanfacine sent to them in a diplomatic bag because it worked really well at just acting as potassium for stimulants, but we couldn't get it. So what happened in 2017, we got approval for the long-acting version of guanfacine, which can work for up to 24 hours. And I sort of describe it to parents as acting like a pro under their focus. and lifting the whole focus up. So it's still the same kid, but now the kid's got started from a higher base. It isn't an effective stimulus. But if you're worried about diversion in the family and a child can swallow because you have to swallow it whole, it might be an option if the family is a little concerned about diversion. Its indicated uses are a second line agent if you've got a contraindication or intolerance to stimulants, horrible tics every time you start, worsening tics every time you start them, or if you've got a lot of anxiety and mood disorders, which even when you can't start it or when you do start it, that gets worse. Or, and this is probably its main use as far as I'm concerned, is an adjunct if you are not responding well to stimulants and you've reached maximal doses. And talked about maximal doses in WA, we'll talk about that in a minute. Or if side effects like appetite suppression are precluding you from pushing that dose in, this is a good way of just potentiating the effects. And off-label in Australia, it is quite a useful tick reducing agent, but it is an off-label prescription. So it depends how comfortable you are with off-label prescribing. Probably we get away with it more than people in general practice land, maybe. But I know the psychiatrists use it that way. Side effects, as you might have met with an alpha-2 agonist, one of these is a non-selective alpha-2 agonist, hypotension, bradycardia, and somnolence. One of the big ones. Somnolence also fatigue, can cause headaches. But weirdly, occasionally it also causes insomnia, which can be just. So I often started in the evening at a low dose. The other is that the slower that you move that dose, the less problematic these symptoms are. When it first came out, the company was saying 1 milligram for a week, 2 milligrams for a week, 3 milligrams, and I had a kid with an unreported low blood pressure. So I now go 1 milligram for at least 2 weeks and 2 milligrams for at least 4, and then reassess them, and I have very few side effects if I go slowly. And initially I skipped it at night because it's much more because somnolence and insomnia. But after about 3 months, you can be looking to the daytime because those symptoms tend to get better. Non-selective alpha-2 agonist clonidine, although it's been around forever. Weirdly, we can use it in much higher doses than you can use it for sedation. It's quite useful in young children with aggression. Actually, it's quite useful calmer for aggressive kids. I often use it in the kids where aggression and symptoms are a bit, and they're either a little young for stimulants, they're 4-year-olds and things like that, where technically you can use it, but you prefer not to sort of get some degree of control, some degree of behavioural control in a way that works for family for a period of time. This is only the very small kids. Very useful in children with sleep disturbance, either because of ADHA or worsening on medication. Quite useful if the stimulant wears off and the child's behaviour rebounds. Or rebound, it's actually worse than having a problem. Tell parents it's like a metaphorical dropping of the clutch. So get metaphorical behavioural burnout, and with all the tiresome that goes with that, and this will help. This can sometimes help just make that a gentle pull away. You have to introduce it slowly because of hypotension, and you've got to be careful theoretically withdrawing it because you can get blood pressure spike. Actually, I think one officer does it far more often, so it's quite dangerous in overdose.
It's used for schizophrenia with adults.
I don't
Or
know.
dope things.
I don't think so.
It's used for hot flushes and menopause.
Don't let kids simply consider it. Because there was a run of kids in ICU with profound hypotension, bradycardia. It's a horrible drug. Atomoxetine, which is brand name traditionally Strattera. Yeah, it's a different brand name, I think. It's a selective noradrenaline reuptake inhibitor. It's an antidepressant. So like an antidepressant, it takes a long time to work. But I don't have much success with it, but from one of the psychiatrists, David Colgill, in Melbourne, he said, because you guys don't give it long enough, you've got to give it at least 3 months. So, yeah, for most families, I don't know how effective waiting 3 months when they're in a crisis, like they often are when they come to see you and they've already waited 2 years, works. But yeah, there are some families that really don't want it. And I have seen miracles. I've seen a child who was sent to juvenile detention, so sent it to Fancy Hill, and that child within 6 months reached their previous of a year.
Maybe they don't. Have you heard what happened to Benson?
Yes. Yeah. But this child became a previous of a year. It was a complete turn. It can be an amazing drug. I just don't have much success with it. You do need to dose it every day. You do absolutely you need to dose it every day. It only comes as capsule, which is a problem for some parents. Yeah, for some kids, it's all capsules. Kids. And it's useful if the child does have some mood issues, particularly anxiety, which is an antidepressant, or you have substance use concerns in the child or the parent, because who particularly wants to divert, he's got no diversion potential. There is a small risk, it's actually smaller than the other antidepressants, of suicidality, particularly if you start with large doses. And there was a child in Brisbane a few years ago who actually did commit suicide whilst dose treatment. But it's actually less than the other antidepressants. You can use psychotropics for managing comorbidities. So, antidepressants, mood stabilizers, antipsychotics, much less of a role, hopefully. Antipsychotics, particularly kids with behavioural disturbance from autism, but also conduct disorder kids that are really severely behavioural disorder. Melatonin. Oh, I like it. Melatonin is a really good drug in sleep disturbance. It's obviously got a bit depressed in the last few weeks. But sleep disturbance common with ADHD is not necessarily related to stimulus. People with ADHD don't sleep very well. They're the people that can survive by having enough sleep. They look great and do all their wonderful thinking at night. And it's particularly good if you've got delayed sleep latency. It is really good for treating that. Obviously, there's been an issue with iHerb and the gummies. The gummies were terrible because gummies had different doses, so they were terrible. And iHerb was withdrawn, so you still can buy it from BioVia. You still can get it across from BioVia, or there are some pharmaceutical versions for their license. Melatonin is just don't let the kids eat the gummies because then you'll overdose, and that's a bit silly, wasn't it? I just want to talk briefly, because I only got briefly, about the monitored medicine prescribing code. This changed in 2014, December of last year. All of the beautiful comments come from the health department in it. Well, I think you discovered on that 16th when they wrote back to you and told you that you don't have to notify anymore. So that we didn't know it changed. I knew it was coming. In fact, I spoke to the chief pharmacist of WACS, or the acting chief pharmacist, and he said, we knew it was coming, we didn't know about the release. So not even the pharmacist knew it was coming. Done all the beautiful comms, health departments, famous. It's been changing. There's actually changed the requirements for prescribing stimulants. And what they've come up with is approved specialists. And I'm just choosing one for ADHD, this one's for brain injury, and this one's for epilepsy. I don't do it with that. I'm not a approved specialist for them, so don't focus at all. But the approved specialists for ADHD are paediatricians, paediatric neurologists, and psychiatrists. There is still a differentiation between child psychiatrists and adult psychiatrists, whether they can do children. There is no need to submit a notification form now if you are prescribing as an approved specialist for one of your approved conditions. And there are no other things like substance use or diversion worries or drug-induced psychosis or things like that, which less of an issue for me as a paediatrician, but an issue for the adults. Which means that has implications down the line for generalists, because the shared care, there is this now thing called the shared care medical practitioner, which was designed to be like shared care of many things, I think, but it was really badly defined in the code. And also nurse practitioners. And they can prescribe continuing treatment if it was initiated by an approved specialist for improved diagnosis. It is for ongoing treatment. You are prescribing in accordance with written instructions, or you are prescribing what's on script check. So you can re-prescribe what's on script check. That's fine. And the other thing is you're supposed to have reviewed the patient. You're supposed to not just issue a script, you're supposed to have reviewed the patient. But you cannot alter the type of the formulation. Now, having said that, the chief pharmacist of the Drugs and Poison Branch, did write to me and say they've been a little bit more flexible recently with the shortages of it. So if you've gone from 40 to 220s, yes, technically you're not allowed to do that, but you are right. They're not going to stop you because they recognise that it's hard. You cannot alter the dose, though, without a written instruction from an approved specialist. It doesn't have to be there, it could be anyone. So long as you've got something. And you can't prescribe if they have an authorisation written on there, which means that there is one of those things like the dose is limited because of the stroke use psychosis or bipolar disorder or something else going previous substance use disorder. Then you have the only person who prescribes the approved prescriber. I said, not an issue for me, but it is an issue in the other. There are age restrictions. You cannot prescribe dexamphetamine under the age of 6. That is actually the GA approval anyway, but that is actually legal. You cannot in Western Australia prescribe to the under 6-year-old. And you cannot prescribe dexamphetamine any form of methylphenidate under the age of 4. I think many of us would have a significant problem with anybody, including our colleagues, who did. Actually, I don't know, you can diagnose it under the age of 4. You know it's coming, but you can't know. And I would be hopeful there aren't too many diagnoses. I guess I'm not saying I'm diagnosed for you, I have, but yes, it should be a last report. Urinary drug screens should happen before treatment on anyone older than 16 or 16 and above. Once again, that's out of our age range for new patients. Used to be 30, actually, so that's actually a change. The other thing that changed was the approved specialist review frequency. So under 18, it's like it was always beforehand, which is yearly, but over 18 and they don't have a comorbidity like substance use, they don't see their specialist until 30s.
That's actually really good.
Yeah. That was a big effort to try and improve access.
Yeah.
But if you need to change the dose, then improve specialist.
So when you say burdens, we can actually write, 16, we can just judge the carriage and give a dose range.
We're not allowed to here. Oh, yes, you can actually. I think under the new one, I think you could write a dose range. But the whole point is, actually, because argue that's a written instruction, so you can actually argue that sort of gets around. I don't know. I don't think that's been tested yet. So,
Something on. That's
in the prescribing code, and I actually have a copy of that for anybody wants it, is that list, which basically just says what I just said. When a generalist can prescribe, basically, who can prescribe what, when, and how is just a simple guideline to what I just said. The future, GP initiated diagnosis and prescribing, Australia-wide. It's been available in Queensland for some years now. GPs can prescribe roughly 4. Most of us have some issues with that. GPs have issues with that, and the uptake actually has been appalling. Well, it's not been appalling. The uptake has reflected the fact that GPs don't feel comfortable doing it. They just don't do it. Western Australia, it's probably the first of the other states, and now New South Wales, Victoria, South Australia, Tasmania, and following. Our first cohort of GPs is now our first cohort of GPs started training on the 31st of October. I don't know what that cohort is.
So it's webinars and you need to be linked in with a psychiatrist. The class booker is doing the training, but you have to apply for it and it's very limited.
It was very limited.
It was a lot.
415 GPs that applied.
Yeah.
I know that's English.
Why? What's the resistance? There's no resistance. They just restricted how.
I think they wanted to work. That's the problem. The other thing
So no, on the Queensland one, they
is free for it.
be free, no training.
Oh, and generally, they're uncomfortable doing it.
Yeah. Sorry.
I think it has its place. Interestingly, the expression of interest for paediatricians and psychiatrists to provide input into the training program, don't forget the training program has started, closed yesterday and was only advertised 3 weeks ago. So that's the biggest concern the College of Physicians, the College of Psychiatrists is every state has got its own way and we'd like something standardised, and B, we're all we'd like some oversight to make sure that we're happy with the training program, because there are some vested interests within ADPA potentially, and we don't know what their roles are. So we feel we've been kept out of it a bit. So, but I'm going to submit my feelings so I can't continue. It's not acceptable to anyone. We have to do something. So to declare it, yes, I put it to the LI, but don't forget it. But to help to guide the training, to make sure the training is relevant to Western Australia and particularly relevant to country Western Australia, because I think it probably won't be.
I just, in New South Wales, certainly the Medicare rebate does not match the time spent.
No, and it winds in. It's certainly a long consult is not going to be enough. There are some resources for parents, cards. Yeah.
I mean, it's assuming if you prescribe medication, people are on it lifelong. Because you already said ADHD tends to decrease over time.
If you've got enough behavioural stuff in place, it used to be said that 94% of people, 94% of adults who are given to treat as children would not be on medications in adult. I think that figure has probably dropped, but it's probably still at 80%.
What I find interesting is the amount of clients I see, women mostly, that are now getting up to ADHD medication because they are now being diagnosed and they're all on the meds. Everybody wants a quick fix. Well, I know. And when I talk with my adult patients, is like, I say, like, reflect on where you are. You built a successful business, you have a degree, you're managing your family. How much is the ADHD actually affecting your life? You've obviously built some strategies in place. So, yes, pursue the diagnosis, but work on the executive skills. And if you still finding that you're actually need a bit more, then meditation skills. Accepted things. I said, I don't say anything about meds, but I said there's lots of ways to manage. Yeah, I do want to move the menopause actually. And menopause does make it worse. Yeah, it does huge. ADHD don't is built up a
ADHD has resources. This is just coming out. This is coming out from cars, not areas. So if they come out, it's on their forward facing, obviously. Yeah, outside face website, because that's how I've got it. And also for parents particularly want medication, I'll just pick one. There's a whole bunch of DLH fact sheets, which I often give to parents. There's one for DS, there's one for methylphenidate, there's one for antihistamine, there's one for cotinine, there's one for melatonin, so they're also there. And I'm sorry, I have got all the time because I can always do it. But
it's very interesting.
No, it's really interesting. Thank you so much for that. We really appreciate it. And so last on for this year. So this has been recorded. We'll shut the recording off. It will be available to rewatch on the recording in there. It will be in my next newsletter. And so, yeah, the website's being fluffed up at the moment, so I get on the website at the moment, but it's still available. So I do appreciate that.
thank you.
A lot. I found it very interesting. So thank you.
Using my clients, I think that legally all I think has been really blessed. It's a very much. Would you appreciate it? No, I appreciate everybody that actually comes along now. I'm not going to be able to get out of this.
Which one?
Oh, stop my recording. Where are we? On that one there. Wasn't transcribed.
Oh, no. Hi, Sue. Thanks. No, Susan Katanara.
Okay.
Thanks for coming again. We're just going to stop.